Welcome back, everyone. So, as I promised, we will do Odell case today, and I would like to start with case one, which is about caries. And you all know it is very important topic for ADC, be it part one or part two. Caries is very important because these are the patient which we would see more commonly when we will practice as dentists in Australia or anywhere else as well. Okay, so I would recommend with this case, try studying the caries topic from TG as well and from Ivan's articles and the ICDS article. So if you will read all these four things together, you would know like the things would follow, and if you try to solve some questions around about the caries, you will get a better understanding about that. Okay, so Odell cases, you all know that it is just like a summary of the patient, how he came to your practice, then how you are, what you ask in history, what examination you did, what investigation you did, and how did it go after that, right? Until the management. So we will be reading this story here. Okay, so here the patient is 17-year-old and he is a student, and he has several carious lesion and one of them is very large. How should you manage his condition? Okay, so first we need to ask about the history. So history, first we will ask the chief complaint, what is the main reason for his visit? He complains that there was a filling here and it fell off on the lower right side and has left a sharp edge now that irritates his tongue. So he has got no other symptom. It's just these sharp edges are irritating his tongue because the filling which was present here was lost. He is otherwise asymptomatic. Then history of complaint. History of complaint means you need to understand how did it all happen, from where did it start. Okay, the filling was placed about a year ago at a casual visit to dentist precipitated by acute toothache. So he has got a acute toothache which was triggering by hot and cold foods and drink. So that's the reason that dentist placed a filling over there. He did not return, so there was the treatment needs to be completed, but he did not completed the course because he moved his house and is not registered currently with the dental practitioner. Then in history it is very important to ask about the medical history. So he is fit and well. Then examination, what examination you did? So for the examination, we all know that firstly we will start from outside the mouth and then we will go inside to look for hard tissue, soft tissue and teeth and the main problem. Okay, so extraoral examination, he is fit and healthy looking adolescent. No cement. So in extraoral examination, we generally check the lymph nodes, cervical lymph nodes and the joint. Okay, so how the joint movement, if there is any tenderness, if there is any palpitations, and we will check. So always remember in extraoral examination, we check the lymph nodes and the joint movement. And then intraoral examination, the lower right quadrant is shown in this picture. The oral mucosa here is healthy. So as we can appreciate in this picture, inside is one, we are seeing that the mucosa looks healthy. There is no redness, bleeding or swollen. And the oral hygiene is also satisfactory. There is gingivitis in areas, but no calculus is visible, and probing depth are 3 millimeter or less. So it means there is only gingivitis, there is no periodontitis because there are no pocket depths, right? The mandibular right first molar is grossly carious, and a sinus is discharging on its buccal aspect. So as we can see here, this is the sinus which is discharging, and we are seeing here like this is the GP point which you place to trace from where this infection is coming from where this sinus is coming from. There are no other restoration in any teeth. No teeth have been extracted and the third molars are not visible. A small cavity is present on the occlusal surface of the mandibular right second molar. Okay, so in the intraoral examination, we will check the patient's soft tissues and the hard tissue and all the teeth in that area. Okay, so first we started with the soft tissue. We check about the mucosa, gingivitis, there was no other problem. Then with the hard tissue, we checked about the teeth, any other teeth being extracted or third molars, where are they present or any other decay. So we found a small cavity is present on the occlusal surface of the mandibular right second molar. So, what investigations would you do? So, for any caries, the best, what is the best investigation from what we start is the cold test, right? So, test of tooth sensibility, it means vitality of the teeth in the region of the sinus. We will check all the teeth in that area to find out from where the sinus is coming from. Even though the first molar is the, even though looking at the picture we can see that there is a very big hole in this tooth and most likely the sinus is coming from this tooth, but we are not sure. Maybe it might be like from any other tooth. We are not sure. We have not done our test and investigation, so we need to be sure first, right, before doing any irreversible treatment, as we studied it in our TG. So, the adjacent teeth should be tested because more than one tooth might be non-vital. So, because this sinus, you all know that firstly the decay happen, then the reversible pulpitis, then irreversible pulpitis, then slowly the pulp would become necrosed, then periapical infection. So, then the sinus forms after the chronic infection is there. Okay, the results should be compared with those of the teeth on the opposite side. So we always compare how the teeth would respond with the opposite side teeth. Okay, so both hot and cold methods and electric pulp testing could be used because extensive reactionary dentin may moderate the response. Okay, we can use any method like hot, cold, and electric pulp testing. But to be honest, more likely what we are using is the cold, which is the cold spray we use. The first molar fails to respond to any test. All other teeth appear vital. So most likely, this is the non-vital tooth. Then what radiographs would you take? Explain why. Okay, so we have taken the history from the patient. We checked his medical history. We did the examination. We did the call test. Now we need to take a radiograph to understand what is happening below in the root area, right? So we will take the X-rays. So they are asking which X-rays would you take. So firstly, they said that bite wing radiograph. It is very important to detect any proximal surface. So a bite wing X-ray is mainly the checkup X-ray, which we take to find out which tooth is actually the reason, or if there is any other holes in the proximal sides. Because with the clinical examination, we can only check the occlusal caries. We cannot check the proximal caries, which is the most likely where caries does happen. Okay, so to check other teeth, we will take biting radiograph, and in this case, also required to help detect occlusal caries. And then periapical radiograph we need of this specific tooth, which is making the which has caused the sinus. We need to take a periapical radiograph of this tooth. Okay, so taken with the paralleling technique, pre-operative assessment for endodontic treatment or extraction should be necessary. So even if we need to do the root canal treatment or we need to take the tooth out, we will need a periapical X-ray to understand how is the root anatomy, right? Then dental panoramic radiograph, it might be useful as just as a general survey view in a new patient. When in new patient we generally do the PG just for a general survey and to determine the presence and position of the third molar. So if the patient comes with any complaint of the third molar, we generally only take the OPG, because and not any other radiograph would be helpful. Okay, so what problems are inherent in the diagnosis of caries in this patient? Occlusal lesions are now the predominant form of caries in adolescence after the reduction in relative caries incidence over the past decades. Occlusal caries may go undetected on visual examination for two reasons. Because, when we see in patient's mouth, we see, like, from the occlusal we can only see a pinpoint, but deep down it could be very big caries. Firstly, it starts on the fissure wall. It always starts from the fissure wall because that is the area where most of the bacteria and food get stuck, and is obscured by sound superficial enamel. Secondly, lesions tend to cavitate late. They just spread first and then they cavitate. So we do not really get to know the idea. And on bite wing x-rays as well, we may sometimes miss them, occlusal caries, but bite wing radiographs are best for the proximal caries, if at all, probably because fluoride exposure reinforced the ionic structure of the overlying enamel. So this is just a concept where they say that fluoride reinforce, or fluoride helps strengthening the overlying enamel that would hide the decay underneath. Superimposition of sound enamel also masks small and medium sized lesions on bite wing radiographs. This small occlusal cavity in the second molar arouses suspicion that other pits and fissures in the molar will be carious. Unless lesions are very large, extending into the middle third of the dentine, they may not be detectable on the bite wing radiograph. So it is the thing that on the bite wing radiograph, we won't be able to see if the lesion is just initial for occlusal caries. Okay, so then the radiographs are shown in figure 1.2. So here they have shown all the radiograph, what you can see from this radiograph. The periapical radiograph shows the carious lesion in the crown of the lower right first molar to be extensive, involving the pulp. The mesial contact has been completely destroyed and the molar has tilted mesially. So same thing, we can see that here there is a big hole. This tooth is tilted mesially, right? There are periapical radiolucencies at the apices of both roots, that on the mesial being larger. So there is radiolucencies. We can appreciate here this black area. The radiolucencies are in continuity with the pedial, and there is a loss of lamina dura in the bifurcation and around the root apices. The bite-wing radiographs confirms the carious exposure and reveal occlusal carious lesion in all the maxillary and mandibular molars, with the exception of the upper right first molar. Okay, so here from the X-ray we can see that, can you see this black area? So there is a occlusal decay in this tooth as well. So here as well. All right, so they said that from all the in all the molars we can appreciate the caries in the bite wing in this patient, except from upper right first molar. If two or more teeth were possible, reasons of the sinus, how might you decide between them? We know that we just put the GP point, which is the flexible, fine sized point is flexible but resilient enough to pass along the sinus tract, and we just put it inside the that sinus, and we take the X-ray, and that would trace the origin of the sinus. Okay, so the what is the diagnosis in this case? The patient has a non-vital lower right first molar with the periapical abscess. So that is the diagnosis, because his tooth was not responding anything to like not any sensitivity or any pain, because he only came because of the irritation of the sharp edges, and there was a periapical abscess which is draining through the sinus. In addition, he has a high caries rate, because we found out on the X-ray that he has all his molar has got the decays except for right first molar. Okay, so he is in high caries risk because he has more than two new or active lesions in 2 years. So you will come to know which patients are high risk, which patients are low risk or moderate risk in Ivan's article if you will read that. So we have found the diagnosis. Now how we will manage it? The patient is horrified to discover because he didn't know that he has got so many holes in his teeth. After the x-ray we came to know and he got horrified. This is just a normal response, right? He is keen to do all that can be done to save all teeth, and a decision is made to try to restore the lower molar. How will you prioritize treatment for this patient? So, what should you do for this patient at this stage? Would you just fill all the other teeth, or what should be your treatment plan? So they mention here what should be your sequence. Firstly, there should be immediate phase, which means if the patient is in pain or if there is any, like here, the sinus is there, so you need to remove that infection or the source of infection, right? Then you need to stabilization of caries. It means removal of carious dentine in any cavitated lesion and place a temporary filling. In other molars where we found out there was decay, in those molars we will remove this, we will do this immediate phase in today's appointment, and later we will book another appointment and we will do this stabilization of caries, in which we will remove all the decay from other molars and put a temporary restorations. Okay, and then we advise and we give the patient some preventive advices. For example, dietary analysis, oral hygiene instructions, fluoride advices, and saliva analysis. Okay, so it means dietary means we will give him the diet chart to fill in to understand why has so many holes happening. He is only 17 years old, yeah, right? So we need to find out the cause, because decay happens due to three things only: either the diet, or if there is any problem in oral hygiene, or any tooth structure. Sometimes the tooth structure could also be weaker, or the saliva could also be not good buffering capacity. So that could be few reasons. So we will check about all these things and we will go through brushing and flossing habits, and we will advise him to use the fluoride toothpaste according to his age. And we can also check his salivary flow rate test to understand if there is any deficiency of saliva which is making him more prone to get all the decays. Okay, so after the preventive phase, if we sees that he is, responding to that and he is doing all those things, then we should put the definitive or the final restoration in those teeth. And then we will always recall the patient and review the patient periodically. It is generally recommended to visit your dentist every 6 months to find out and for just for checkup or all these things. Okay. So then they mentioned that what temporary restoration materials are available and what are their properties. So there are certain type of temporary restoration material. You can read about them, and these are their properties, and these are the situation where we favor one over the other. Then, which is one molar? So, why is one molar so much more broken down compared to the other? It is difficult to certain, but the extensive carious lesion is probably in part a result of previous failed restoration. There might be any because he got any restoration done, so there might be the restoration has failed. In view of the pattern of lesion in the other molars, it seems likely that this was a large occlusal restoration, and the history suggests that it was placed in a vital tooth. It means that his tooth was vital, right? So reversible. It probably undermined the mesial cusp and the marginal ridge was broken. So the marginal ridge is the most prominent part of the tooth structure, you all know. So because this tooth, the hole was very big to start with, so there was a very big filling, and with the big filling, it is always a risk that they can fail. Two factors could have contributed to the extensive carious lesion only 1 year later, which is the margin. Sometimes there would be a marginal leakage from the margins and undermining of the marginal ridge or mesial cusp, leading to mechanical collapse of the tooth restoration junction. So that's the reason there is a gap between the tooth and the restoration where bacteria are seeping in and causing the infection. Should you ensure removal of all carious tissues when restoring the vital molar? So here this says that removal of all soft carious lesion is very important, but you can still leave the hard one. Okay, so which is mainly the affected and the affected dentine. So here they state that affected dentine, which is the soft part, you need to remove it, you cannot leave it. But which is the affected dentine, which is hard, okay, you can still leave it. But it is a very difficult situation to make, and the decision rests to a degree on clinical experience. Physically interpreting softened dentine is rapidly and in rapidly advancing lesions is difficult. The deepest layer are soft through demineralization but are not necessarily grossly infected. So it is a situation where you can leave the affected dentine, but you need to remove the affected dentine, which is the soft part. So, if about this case, about this minimal invasive operative, we will read in case 9. So, they have discussed in whole chapter like what is this called and how does that all the process happen. So, what preventive advice would you do? Which is the dietary analysis. First, you will give the diet chart to the patient to fill in, and then you will modify the diet. The metabolically active caries process requires dietary sugars, in particular sucrose, and because these sugars like sucrose, glucose, fructose, and the plaque flora and susceptible to surface and time to encourage the progression. We all know those four circles for the caries, right? So those are the reason why the caries happen. So we need to find out which circle is the reason in this patient. Okay, just a minute. Okay, then no preventive measures affecting the flora or tooth is as effective. A further advantage on of emphasis on diet is that it forces patients to acknowledge that they must take responsibility. So whenever we are managing the decay or all these things, it should always be two-way process, like right. So we are doing the fillings for the patient, and we are doing some preventive measures like fluoride varnishes and fissure sealants. But from the patient also we need his contribution in making in taking healthy diet. Try to like gives his teeth at least rest for 2 hours, and do not end your meal with the sugary diet, right? And like you can take like colas and sodas, but only with your food. Do not snacks a lot, and all these things, and even the brushing, flossing, we need his part as well too, if we really need to manage the caries. How would you evaluate a patient's diet? So this is a process where we need to find out like I'll show you here. So here they have highlighted all the all the areas where the patient is taking the sugary diet, right? And he's snacking a lot. So in the diet, we generally asks the patient like which type of diet he is having, like does he having sucrose or does he having like sugary diet and acidic diet or not. Then we need to find out what is the frequency, because frequency is more important than quantity, because we need to give at least 2 hour rest to our teeth, because that is the time when saliva would overcome and it would buffer all the acid produced by the bacteria during our eating time, right? So it is very recommended to find out the frequency of eating and which type of diet they are eating, like sugary or acidic, and what is the texture. Sometimes if the diet which they are having is sticky in nature, like for example muesli bars or any other sticky diet, so that would stay with on their teeth for the longer time. So that is also an negative point, right? So that would also increase the chances of bacteria to get active and cause infection there. Okay, then, and the most effective method is the 4 consecutive days, in which 2 working days and 2 weekends. You need to ask them to write everything which they are eating or drinking in those 4 days. But this is generally a UK based book, so they have written here 4 days. According to Australia, it is like 2 weekdays and 1 weekend, and they should write this diet honestly, must be stressed, and of course the diet should not be changed because it being recorded, because sometimes they would try to make you happy, make their dentist happy, that's why they would skip the unhealthy part. But you should enforce that, try to write everything honestly, so that's the way where you would be able to help them in a better way, right? So, how would you analyze it? Like, we will highlight sugar rich foods and drink. We would check the number, it means the frequency of sugar exposure, and the consistency. Like, if the food is dry and sticky food, it would take longer to go away. And we would also try to find the hidden sugar, so which is very important part. Sometimes we do not know that, like, this product does contain some sugar in it. For example, baked beans, breakfast cereals, ketchups, or plain biscuit, because they are hidden sugar in them. Those are the natural sugar which are present, but they are not very. We think that this is not a sugary food. We can eat it because, so that's the reason always when you go and buy anything, you should advise your patient to read the labels. So that's the way you can do a healthy shopping for yourself, to find out if there is any hidden sugar, because hidden sugar are also equally damaging as the artificial sugars. Okay, so the diet sheet shows that the main problem of this patient is too many sugar containing drinks and frequency, because here he is taking so many, one slice cherry cake, one slice cake tea with 2 sugars, beans, checker, orange, one cola drink, tea with 2 sugars. So every now and then he is taking sugar. So that is the main reason. And WHO recommends strongly that intake of free sugar should not exceed 10% of total energy consumption. This equates approximately to 50 gram person per day, 50 gram per person per day, or 18 kg per person per day. Okay, so what advice will you give to the patient? So this is, they have written in 1.4 table. Reduce the amount of sugar, like do not take it more than 10%, as it is not recommended by WHO. So always read label, check manufacturer's labels, and avoid food with sugar such as sucrose, glucose, fructose, and natural sugar like honey, brown sugar are also as carcinogenic as added sugar. Okay, and restrict frequency, reduce the amount, restrict the frequency, give your break, give some break to your teeth. Okay, so that is, and have safe snacks such as cheese, crisps, and fruits, or sugar free sweets such as mints or chewing gums. And speed clearance of sugar from the mouth. Never finish your meal with the sugary food or drink. Follow sugary food with a sugar free drink like chewing gum or a protective. Like always end your food with the sugar free drink or food. Like do not end your sugar food with the sugar. Okay, so here they have written, like, I'm just doing it quickly because I feel if I would explain each and every word, then it would be very long um, recording. And yeah, so you can read in depth, but the main things are only these which I'm highlighting here. So here they have shown like this tooth is restored and months after endodontic treatment, what would you see and how would be the long-term problem is evident. So here the long-term should be like the marginal ridge is not there, right? So as that is the most important part. So we would that is a consideration. And there is some bone healing around the Pisces in the bifurcation. Complete healing would be expected after 6 months to 1 year. At each time, the success of the overall root canal can be judged. As noted in the initial radiograph, the lower right first molar has lost its mesial contact and it has drifted. It makes it impossible to restore the normal contour of the mesial surface and contact point. The mesial surface is flat and there is no defined contact point. In the long term, there is a risk of caries of the distal surface of the second premolar, and the caries is likely to affect the wider area of tooth and extend further gingivally compared with caries below a normal contact. Because there is no contact in this restoration and this is flat, so there is more likely there is a chance that this premolar can also get the decay on its distal surface, and it would be a broad decay because there is very broad contact point. Therefore, this tooth would require a crown for long term because this is very weak, very big restoration with the root canal. So the tooth is very weak. So we need to put a crown on top of that. Why not simply extract the lower molar? Extraction of lower molar would also be the preferred treatment. The because the caries was very big and restoration of the tooth would be complex, expensive, and problems will probably ensue in the long term. Okay, the missing tooth might not be readily visible because this is the back molar, it won't be very visible. To a large degree, the decision depends on the patient's wishes and the advices from the oral healthcare team. If the patient would be happy with an edentulous space, the extraction appears to be an attractive proposition. However, if a restoration is required, a bridge will require preparation of further teeth. Of two further teeth, a denture-based replacement is probably not indicated, but an implant might be considered at a later date. Any hesitancy or like this is patient's decision, he wants to save the tooth, so we should save the tooth, but we need to make him understand like there is problems. Even though the root canal treatment is expensive, we need to put the crown on top of that, which is also an expensive procedure, but still the prognosis would not be much great because the very much amount of tooth structure is lost. Extraction would be the better option, but it all depends how the patient would like to go ahead. And these are the medical legal consideration which you need to keep in mind. You need to take the pictures, you need to write in your notes whatever the patient has said to you and whatever is going on. It is very important because if at any stage patient would say like, no, my dentist didn't mention this to me, or anything can happen, right? So you should have something in your hand to which would help you. Okay, so thank you so much, and let me know how did you like this Odell case, and if you want me to make more videos on Odell cases, and how should we go, like just the overall summary, or read each and every line, or how should we go? Please let me know, and thank you so much for watching. Thanks.